Welcome, everyone. It is my absolute pleasure to introduce Dr. Lisa McFadden. I've known Lisa for over a decade. She is an amazing individual and an absolutely fabulous scientist. She's currently an associate professor within the Division of Basic Biomedical Sciences at the Sanford School of Medicine at the University of South Dakota. Before she joined faculty at the University of South Dakota, she got her PhD in neuroscience and behavioral psychology at Northern Illinois University. And then she did a postdoc at the University of Utah. This is where I actually met Lisa when she was working with Annette Fleckenstein, working in rat method self-administration models, and we were collaborating. Her laboratory currently focuses on substance use disorders, including methamphetamine. The techniques she utilizes span from preclinical models to wastewater and informatics. The goal of her research program is to develop more effective and accessible intervention treatments to help those with substance use disorders. She is co-director of SPURA, an undergraduate research fellowship program that's sponsored by the National Institute on Drug Abuse, and GRISE program sponsored by the National Institute of General Medical Sciences. The GRISE is funded by a T32 grant with the goal of training a diverse pool of highly qualified biomedical scientists that are prepared for a variety of career paths in public and private sectors. So without any further delay, please join me in welcoming Dr. McFadden as she tells us about substance use and the influence of rurality. Thank you very much, Lisa.
All right. Well, thank you, Rick, for the wonderful introduction, and thank you all for having me here. It's certainly a pleasure to get to talk with you all. So today we're going to be talking about substance use disorder, particularly since the pandemic hit, and particularly in our area of the country. So I think you all are aware of, we live in the Midwest. A lot of people know them as the flyover states if you're from the coast, but we have a lot of wonderful things in our area of the country. We, in particular, are in the Great Plains here, which is in the green. But in general, one thing that is common among our Midwestern states is that we have a lot of space and not as many people. So we have a low population density. And this affords many luxuries. We get to see green grass, we get to see trees, we get to have yards and gardens and many of those things that we come to appreciate. But one thing that it kind of inhibits a bit is our accessibility to specialty healthcare and just healthcare in general. If you live in a large urban center, you're more likely to be able to see many different physicians. You'll have choices of hospital systems, and you'll have choices of specialty care. Because we have fewer people, we tend to have healthcare shortages. Each year, HRSA produces maps showing healthcare shortage areas for different types of healthcare. On the left, we're looking at HRSA healthcare shortage areas for mental health providers. And you can see in the Midwest, the vast majority of the land is considered underserved for mental health care providers. On the right, we're looking at healthcare shortages for primary healthcare, so our basic type of healthcare professional. And you can see, especially in the Dakotas and northern Minnesota, we have large areas of land that are considered underserved for primary healthcare. Despite having these barriers to healthcare, our average life expectancy is actually greater than the national average. Here we're looking at the area in green here, and the CDC has an average life expectancy of people residing in this area of 77.38 years. This is in comparison to our national average of 76.62 years. So there's many factors that might be driving this, but one factor we do know is influencing this average life expectancy is substance use disorders and drug overdoses. Prior to the pandemic, we saw an increase in drug mortality levels ranging from about 38,000 in 2010 and nearly doubling to about 70,000 in 2019. Then the pandemic hit, and we saw this merging of epidemics. So we had a lot of stress and uncertainty due to COVID-19, and unfortunately, it helped synergize the ongoing drug epidemic. We hit over 100,000 drug overdose deaths in a single year, which is a very unfortunate milestone for our country. So we saw the substance use, in particular drug overdose deaths, increase dramatically during the pandemic. So we in the Midwest we're few people. We are medically underserved, and if you look at nationally representative research, because we have such few people, many times it's hard to understand what is going on in our area of the country because we are not included as much in these surveys given our low population density. So one thing I wanted to look at is how substance use disorder changed in the pandemic in our area of the country. So to do this, we're going to be looking at a variety of things. First, we're going to explore pre-existing differences in substance use disorder in frontier and non-frontier populations. Then we'll investigate how people navigated resources early in the pandemic, explore changes in substance use disorder diagnoses during the pandemic, and then examine how the treatment of opioid use disorder changed during the pandemic. So first, we're going to look at pre-existing differences in substance use disorder in frontier and non-frontier populations. So I had already alluded to this before, but here in South Dakota, we are largely medically underserved. The entire state is considered medically underserved for mental health care, and about 90% of the counties are considered underserved for primary care. So there's some very real barriers to receiving health care in our state. I also wanted to take a second and introduce what frontier is. So frontier and remote is a term by the USDA that describes a territory by some combination of being a low population size and high geographic remoteness. Frontier and remote is defined by the relationship of the time it takes to drive by a car to the edge of the nearest urban area. And why this is important is that these urban areas many times are those hubs for advanced medical care, whether that be a mental health professional or other healthcare professionals. So for this first study, we wanted to look at if emergency department visits for substance use disorder or suicidal ideation differ between our frontier and non-frontier patients. Specifically, we wanted to look at a time period before the pandemic to get some baseline indicators of what substance use looks like prior to this major event. So we looked at South Dakota syndromic surveillance data from 2017 to 2018, where we queried ICD-10 codes for substance use disorder and suicidal ideation. We mapped on frontier and non-frontier status based on the zip code the patient provided, and we also have controls matched on sex, age, and zip code. So this was the demographics of the patients seen by these emergency departments. We saw our frontier patients had a slightly higher proportion of visits that were by males compared to our non-frontier patients. We also saw that our frontier patients were much more likely to be older, which is very consistent with what we know from census data, in that our more rural population is aging. Overall, our frontier patients were more likely to receive a substance use diagnosis. This was true for both a single form of substance use diagnoses and also for polysubstance use diagnoses. So about 5.8% of all visits by frontier patients had some form of some form of substance use disorder diagnoses. For non-frontier patients, this was only about 4%. And overall, alcohol use disorder and nicotine use disorder were the most common forms of substance use disorders diagnosed in these patients. For both our frontier and non-frontier patients, about 2.5% of the visits received alcohol use disorder diagnoses. And for nicotine use disorder, we actually saw significant differences among our frontier and non-frontier patients, with our frontier patients having a higher rate of nicotine use disorder compared to our non-frontier patients. In contrast, the patients residing in non-frontier locations had a higher percentage of cocaine use disorder diagnoses and psychoactive diagnoses compared to our non-frontier or compared to our frontier locations. And the remaining forms of substance use disorder, such as opioid and stimulant use disorder, were largely similar between these two populations. Unfortunately, in South Dakota, we do know that we have higher than average rates of suicide completion, and this is something we really want to address in our population. So we also wanted to look at does substance use disorder influence the odds of a person receiving a suicidal ideation diagnosis. So here we're looking at the odds of a patient receiving this suicidal ideation based on alcohol or other forms of substance use disorder diagnoses, or if they live in a frontier status. We see that our most common forms of substance use disorder, alcohol and nicotine use disorder, increase the odds of a patient receiving a suicidal ideation diagnosis by about 2 to 5-fold. And we see that opioid and stimulant use disorder increase these odds even more, albeit our error bars are fairly large here. So all the forms of substance use disorder increase the odds of a patient receiving this suicidal ideation diagnoses. We also see our patients residing in our frontier locations have a higher odds ratio of receiving this suicidal ideation diagnoses as well. And we speculate this is in part due to those barriers for access to healthcare, especially related to mental health in our more frontier and remote patients. That emergency department is one of those areas that is accessible to them, and therefore they're seeking out care there. So in summary, our frontier patients were more likely to have nicotine use disorder and had a higher odds ratio when looking at suicidal ideation, but lower percentage of cocaine use disorder diagnoses compared to our non-frontier patients. And all forms of substance use disorder increase the odds of a patient receiving a suicidal ideation diagnosis. So this was prior to the pandemic, and we know that the pandemic changed a lot of things. So the pandemic caused a lot of changes in a little bit of time. All of a sudden, people were no longer to be able to send their kids to school. They all of a sudden became the teachers for their children. Daycares were closed, hospitals were closed, businesses were closed, and we saw a lot of disruption in our everyday lives. This is a time of a lot of stress, whether that be stress related to mental health, stress related to economic stability, and stress related to health. There's a lot of resources disrupted during this time, but one resource that remained accessible during this time was our Helpline Center. So our Helpline Center is a free resource accessible to everyone in the state. It can provide a lot of information, a lot of resources related to a lot of different things, including finances, family, healthcare, or disaster. It also is a critical resource for people experiencing a mental health crisis or people who are struggling with substance use disorder. So we wanted to see how did South Dakotans navigate the pandemic during our first surge of COVID-19. So this was around late September to early December 2020, and it corresponds to this wave right here. So this was a time period when we had a lot of uncertainty. This is when we were still unsure that our hospital systems were going to be able to support our healthcare needs during this time period, and we were still really adjusting to this pandemic. So we wanted to look at a large number of metrics. We looked at helpline calls, including total calls, housing-related calls, and healthcare-related calls. And we also looked at calls related to mental health and substance use disorder. We compared this to things related to COVID-19 clinical cases, including county cases, 7-day average county cases, and South Dakota 7-day average cases. And lastly, we looked at wastewater metabolites for alcohol in the county that we have these COVID-19 cases. If you talk to me for very long, I can talk a lot about wastewater epidemiology and how wonderful it is. It provides a really great snapshot of a community's health without having to ask people to reveal personal information about themselves. So it gives us a good idea of what's going on in the community and has a lot of predictiveness, as we saw with COVID-19. So here we're looking at alcohol metabolites, and particularly ethyl sulfate, which is in the orange bars, and we're comparing that to 7-day averages for COVID-19 cases, which is in the blue line here. And if you squint at it, especially after that first month, their alcohol metabolites tend to follow a very similar pattern to what we see with our 7-day averages for COVID-19 cases in our state, with alcohol metabolites peaking just after our peak of COVID-19, which makes a lot of sense. But we have this peculiar increase during that first month. And we thought about it some more. We really came up with no good answers, so we resorted to Googling what was happening during this time period. And when we did, we found out that this corresponds to the time that the public learned that we've exceeded 1,000 new cases of COVID-19 in a day. This was a huge milestone for our state. And this was also the time period where we were seeing a lot of those news stories with the hospital systems across the country being overwhelmed, people having to set up tents to provide health care, and we were really uncertain whether we were going to be in that boat soon or not. So after we hit this milestone, the news headlines tend to calm down as well, and we actually did see that drop in wastewater metabolites. So we looked at correlation among variables here. We're going to first look at COVID-19 cases and total helpline calls. And we see as COVID-19 cases went up, we also saw an increase in helpline calls. So people were using this as a resource to provide information. This was true when we looked at COVID-19 cases, especially our 7-day averages and calls related to healthcare, as well as calls related to housing. Unfortunately, we do not see that positive correlation when we look at COVID-19 cases and calls related to mental health. In fact, we actually see a negative correlation. So as cases went up, we saw fewer calls related to mental health or substance use disorder. And unfortunately, we saw this negative correlation between helpline calls for mental health and substance use disorder in our alcohol metabolite ethyl glucite. And when we look at these variables on Tuesday, which is one of our sampling dates, we do see that there's a significant correlation between COVID-19 cases and our alcohol metabolite. So as cases went up, we also saw an increase in alcohol metabolite. We speculate that people may have been using alcohol as a coping tool to deal with the stress of these increased cases. And we still see that negative correlation between our alcohol metabolites and our helpline calls related to mental health care. Overall, though, it does provide evidence that our helpline was utilized in an effective manner, especially related to housing and healthcare. We still see a positive correlation between our COVID-19 cases and our total helpline calls, as well as our helpline calls related to housing. And there's still a positive correlation between helpline calls related to healthcare and COVID-19 cases, albeit it's just below our significance threshold. And then lastly, we're looking at Fridays here. And again, we see that positive correlation between COVID-19 cases and helpline calls, as well as a very strong relationship between COVID-19 cases and calls related to healthcare. Again, we still see that positive correlation between COVID-19 cases and housing. It's just not quite significant. And the same is true for alcohol metabolite and that negative correlation between helpline calls related to mental health and substance use disorder. Unfortunately, we've had a bit of time to follow up this data, and our metrics have not have been a little bit grim. We have been seeing a more alcohol-related mortality in the time that has passed since then. So, according to the CDC, our alcohol-induced mortality for the state of South Dakota increased from about from 2019 to 2020 by 41%. And our chronic liver diseases and cirrhosis, many times alcohol use contributes to these diseases, increased from 53% from 2019 to 2020, and it's doubled from 2019 to 2021. In fact, in South Dakota, it was the 8th most common cause of death in 2021. So we are seeing metrics that perhaps to also confirm that perhaps people were misusing alcohol during this time period, and this is leading to a negative impact on people's health. So overall, we found that our helpline was really critical for helping people navigate resources during this very uncertain time. So there was that significant correlation between COVID-19 cases and calls related to housing and healthcare. We don't see that relationship when it comes to mental health care calls or substance-related calls. But we did see a positive correlation between COVID-19 cases in the county as well as wastewater metabolites for alcohol, and a negative correlation between that and mental health care calls. We wanted to take an orthogonal approach, though, and look at how alcohol use disorder changed using a different metric as well. So we wanted to see how did substance use diagnoses change during the pandemic in our area of the country. And to do this, we partnered with Sanford Healthcare. So Stanford Healthcare is one of the leading rural healthcare providers, and they're centrally located in the Midwest. They have a large footprint, especially in the Dakotas and Minnesota, but are rapidly branching out to other areas of the Great Plains. So we looked at their electronic health records between March 1st, 2019 to March 13th, 2021. So about a year prior to the pandemic and that first year of the pandemic. And we looked at diagnoses related to alcohol use disorder, opioid use disorder, and stimulant use disorder. This resulted in just under 110,000 records of visits from patients, and this is about 33,000 unique patients. We did limit this to patients who were over the age of 18 and those residing in the Midwest. Based on the zip code the patients gave, we mapped on whether or not they lived in a rural or non-rural setting based on RUCA codes. So specifically metro, if they had RUCA codes 1 through 3, and non-metro for RUCA codes 4 through 10. And we also included Medicaid expansion status for the state at the time of visit. So here we're looking at alcohol use disorders, specifically the odds of receiving this diagnosis. This is a bit of an abnormality compared to the other diagnoses we'll be looking at. So patients who resided in the non-Medicaid expansion states were more likely to receive these diagnoses, as well as patients who lived in a metro location. Alcohol use disorder was more commonly diagnosed during the pandemic, which aligns well with what we saw with mortality rates and also our alcohol metabolites. And it was more common in males compared to females. In contrast, when we look at opioid use disorder diagnoses, we see that is more commonly diagnosed in patients residing in Medicaid expansion states. We speculate this isn't simply because there's more people misusing opioids in these states, but rather this Medicaid expansion helps build healthcare infrastructure, which allows these patients to be seen for their healthcare needs. We also see that people who reside in those non-metro settings were more likely to receive this diagnosis, as well as females. This diagnosis was actually more common prior to the pandemic compared to during the pandemic as well. And here we're looking at stimulant use disorders. Again, we saw that Medicaid expansion significantly increased the probability of a patient receiving this diagnosis. Again, we speculated simply due to building that infrastructure for healthcare and not due to the actual number of people misusing stimulants in these areas. Again, we saw that this was more common in females compared to males, and it was actually more common prior to the pandemic compared to during the pandemic. Next, we wanted to look at stimulant use disorder that was in remission. So the remission diagnoses are those just ICD-10 codes that end in a 1. So this wasn't, I want to make it clear, we're not using this as a metric of a patient's journey and recovery, because we don't believe that that is a good metric of that. Rather, we want to use this as a metric of a conversation or some sort of attempt for follow-up care between a healthcare provider and a patient. In order for this patient to receive this diagnosis, somewhere along the way, a healthcare provider had to make an attempt to inquiry about their current journey to recovery. So this was from the same patients we were looking at before in the same visits as well. So when we look at alcohol use disorder in remission, we see again and consistently across all our remission diagnoses that it was more common in patients residing in that Medicaid expansion states. So again, we think that this Medicaid expansion simply helps build infrastructure for receiving care. Again, we see that this is more common in patients residing in non-metro locations, and it was more common prior to the pandemic than during the pandemic. And lastly, more common in our females compared to males. When we look at opioid use disorder remission, again, we see those conversations are more likely to occur in patients living in those non-Medicaid or in Medicaid expansion states, patients living in non-metro settings, and in females as well. This was also more common prior to the pandemic than during the pandemic. And finally, when we look at stimulant use disorder, again, that Medicaid expansion led to a significant increase in odds that the patient receive this remission diagnosis. Again, we see that living in those non-metro settings increases odds as well, and we speculate that perhaps due to a lower patient volume, it might provide the healthcare provider a bit more time to talk with their patients about their current health status. We see in our this population too that it was more common during the pandemic as opposed to prior to the pandemic and in our females compared to our males. So overall, we saw our alcohol use diagnoses increase during the pandemic, which aligns well with what we saw with wastewater data and what we saw with CDC mortality rates related to alcohol use. This disorder was more common in the non-Medicaid expansion states and more common in people living in metro locations and males. For opioid use disorder, we saw the opposite. It was more common in those Medicaid expansion states, and it was more common in our female population compared to our males. And overall, those remission diagnoses were much more common among patients residing in Medicaid expansion states. Again, we speculate this Medicaid expansion just helps build infrastructure to provide care, and more common in patients residing in those non-metro settings, as well as patients who are female. So lastly, we wanted to look at how opioid use disorder, and particularly the treatment of opioid use disorder, changed during the pandemic. So prior to the pandemic, we had known that the Midwest had a significant shortage for care for people with opioid use disorder. Particularly, we're looking at buprenorphine here, and the counties in white indicate that there is no provider with a DEA waiver to prescribe buprenorphine. And this is just a treatment for opioid use disorder. The counties in green indicate that there is a provider. You can see in our Midwest, there is a lot of white in this area. So there's a lot of counties where there is no provider to provide this very important medication to treat opioid use disorder. If we look at methadone, which is another treatment for opioid use disorder, we'd see that there would be far less accessibility to this treatment in our area of the country. So we wanted to see if this changed during the pandemic. Specifically, we wanted to look at access to buprenorphine by quantifying changes in buprenorphine prescriptions, particularly in our rural and urban settings. So we queried Sanford's electronic health records for visits where buprenorphine was prescribed. And we looked at 55 weeks prior to the start of the pandemic and 55 weeks after the start of the pandemic. So here are demographics of this population. We see that the majority of these patients were female. The majority were not Hispanic. There is a mixture between white and Native Americans in this data set. And the most common age was between 21 and 35 years old. And the majority of these visits were by patients living in a frontier location. Again, this is Sanford's electronic health records, and they are very much a rural healthcare provider. So it's not completely surprising that we see so many more patients residing in a frontier location. So here on the left, we're looking at the number of visits where buprenorphine was prescribed per week. The blue circles indicate patients who lived in a frontier location, whereas the red circles indicate patients who lived in a non-frontier location. The dashed line down the center indicates the start of the pandemic, and on the left here, we're looking at patients who are male. We do see that after the pandemic hit, we did see a significant increase in the number of visits where buprenorphine was prescribed, especially for those frontier patients, albeit it's not a very big increase. When we look at the females, though, we see a much more robust increase in visits by patients who reside in the frontier locations after the start of the pandemic. We saw a quite consistent increase in the number of visits per week where buprenorphine was prescribed. We had a very helpful reviewer that asked us to look a little bit deeper and see what changed during this time. So particularly, we looked at who was prescribing. Overall, the vast majority of prescriptions were written by a physician. However, when that pandemic hit, we saw in our populations that reside in frontier locations, that the nurse practitioners entered into treatment for these patients. So over 10% of these prescriptions were written by a nurse practitioner during this time period. So it appears something changed that better enabled nurse practitioners to treat these patients. So there was actually a lot of things that changed during this time period. Previous studies have shown that access to buprenorphine is limited in people who reside in rural locations. Some of the barriers that people cite are finding a provider and getting an accessible provider, finding transportation to get to those appointments, the cost associated with not only the medication, but getting to and from, and then stigma associated with receiving this treatment. We saw a lot of changes in policy during this time period, and some of these policy changes may have helped mitigate some of these barriers. So we saw that practitioners, especially physicians, could prescribe up to 30 patients at a given time without having to go through a full DEA waiver. And we also saw that telehealth could be used to initiate and continue care for patients with substance use disorder, in particular prescribing buprenorphine. So some of these changes may have helped mitigate these barriers, especially when it comes to finding those practitioners and getting to those appointments, such that it might have become more accessible, especially to our frontier patients. So our working hypothesis is especially those changes in telehealth and policy may have mitigated some of those access barriers, some of the need for transportation, and perhaps even increase privacy and decrease stigma, given that they could have these appointments in the privacy of their own home. And some of these changes or some other factors may have better enabled rural practitioners to better serve their patients. If you've been to a rural healthcare clinic, you probably know that you're more likely to be served by a nurse practitioner or a physician's assistant. So having these nurse practitioners enter into the field of treating these patients is actually a really important change. So overall, we saw some good findings from these data sets. We saw during the pandemic, we have an increase in accessibility for buprenorphine, which is a medication used to treat opioid use disorder, especially among patients who are women and patients residing in those frontier locations. We also found new providers entering into the field of treating patients with this disorder. We saw that our helpline provided some really critical information at navigating many of the challenges faced during a time period of uncertainty at the beginning of our pandemic. And we saw some attempts for follow-up care through those remission diagnoses occurring, especially in patients who live in those non-Medicaid expansion states and patients residing in non-metro locations, as well as patients who are female. However, we found some not so great findings as well. So there was some pre-existing geographic disparities with patients residing in those rural locations being more likely to use tobacco. We also saw these frontier patients had a higher rate of suicidal ideation, at least when looking at syndromic surveillance data. Overall, alcohol use disorder was common among emergency room visits, and alcohol misuse may have increased during the pandemic. And we saw this both with our wastewater data, our electronic health records, and we saw this with mortality rates as well. So not only do we have a need to treat patients with these forms of substance use, so tobacco use disorder and alcohol use disorder, but we have a need to provide continuing care for patients and the diseases associated with these disorders. So we know that tobacco use can lead to lung disease. It can lead to cancer and cardiovascular disease. Alcohol use can lead to liver diseases and a variety of other diseases. We're going to need continued care for many, many years to come for these patients and their needs associated with these disorders. So we really had some unprecedented times due to the pandemic, and it did lead to a lot of changes in healthcare policy. One thing I want to encourage everyone is to critically look through our outcomes during this time period and see what worked for the better and what did not work for our given populations. Particularly, how do we provide the best patient care for people with chronic diseases in the Midwest, including substance use disorder? How do we look at healthcare policy changes and decide what should be made permanent? And how do we provide the best patient care for patients living in rural and underserved areas of our Midwest? And with that being said, I just wanted to thank the Center for Health Outcomes and Population Research, including Jill Weimer, our cores and personnel there, as well as Marie Severson, Jay Butler, and Ahmed Nahayan. Dr. Victor Huber from USD, who helped with the wastewater data, as well as Dan Snow at the University of Nebraska, who also assisted with this, and the South Dakota Department of Health. And lastly, I wanted to thank my funder, NIGMS, for supporting this research